Good afternoon, everyone. I'm Bridget Ryan, and I think I know everyone here now. And on behalf of Stuart Harris and I, we have had the pleasure of supervising Dr. Carolyn Rebicki, and we're very pleased to welcome you on behalf of the Family Medicine Graduate Program to her public lecture for her Family Medicine Masters of Clinical Science. Our format today is that Caroline is going to give us a talk. It's about 20 minutes, and after that there will be some time for questions, and I would just like to remind our examiners to please withhold your questions until the actual defense, if you don't mind. So it's now my pleasure to introduce Caroline. Dr. Rebicki is a Brazilian family physician. She's been practicing in the public health system in Brazil for 13 years. She's also an assistant teacher at Positivo University Medical School in Curitiba, Brazil. Last year, Caroline was hired by Dr. Gustavo Gusso to be part of his team as a medical coordinator for primary care at United Health Group Brazil. And this group their mission is to reorganize primary care in the Brazilian private health system. The fun fact is that Dr. Gusso is one of our MClSc alums, and the two of them met at our MClSc 40th anniversary symposium. So we're kind of pleased that we brought them together in Canada so that they're now working together in Brazil. Since joining United Group Brazil, Dr. Rebicki has been involved in a number of projects, including implementing family health teams, developing a primary care mental health reference program, and organizing a continued care program for patients discharged from the hospital with family health teams, and also writing a thesis. Caroline believes that to improve population health and sustainability in health systems in her country, a primary care revolution will be necessary. And she believes that this includes improving the quality of research in primary care in Brazil. On a personal level, Caroline enjoys being a mom and traveling and cooking and sharing great stories, just like a good family physician does. We are so pleased to have you here today in person, Caroline, and I'm going to turn it over to you.
Thank you. Hey. Thank you. It's great to be here. Thank you all for coming. Before I start, I want to recognize and thank the wonderful people who have helped me to make this thesis possible. My supervisors, Dr. Stuart Harris for his proficient advice and support and guidance, Dr. Bridget Ryan for her immense patience and graceful guidance and support, Dr. Paul Tremblay for statistical advice, my father and mother, Walter and Beatrix, for always inspiring me to reach higher grounds. I also wish to thank my husband, Rafael, and our children for encouragement. The outline for this presentation is the following. In 2017, the International Diabetes Federation estimated that 425 million adults currently had diabetes. There will be 629 million people with diabetes in the world in 2045. That's an increase of 48%. Canada has also seen rising rates of diabetes. In 2017, the estimated prevalence of diabetes was 3.5 million, or 9.6% of the population aged 20 to 79, and it is predicted to rise to 10.5% of the population by 2045. Diabetes and its related problems are frequent reasons for patient-physician encounters in primary care worldwide. One of the issues that requires special attention from family physicians is the risk of hypoglycemia in their patients with diabetes on insulin and/or secretagogues. The ability to appropriately identify and manage this medication-related adverse event is a central competence of diabetes care. Despite importance of the management of hypoglycemia to overall diabetes care, literature on family physicians' awareness, actions, and attitudes toward hypoglycemia and appropriate treatment and intervention in primary care is substantially limited. The Canadian Diabetes Association defines hypoglycemia by three components: development of autonomic and neuroglycopenic symptoms, plasma glucose level below 4 millimoles per liter, symptoms responding to administration of carbohydrates. Hypoglycemia is commonly associated with people with type 1 diabetes, but it's also seen in type 2 diabetes managed by insulin and/or secretagogues. In a paper by Radsky-Lewig et al., the authors found that the incidence of hypoglycemia among adults with diabetes taking insulin or secretagogues is higher than previously thought. 83% of people with type 1 reported having experienced at least one hypoglycemic event. 62%, surprisingly, of type 2 diabetes individuals experienced the same rate of one hypoglycemic event. As such, it is important to prevent, recognize, and treat hypoglycemia episodes secondary to the use of insulin or insulin secretagogues. Management of the patient with diabetes embodies the spirit of primary care medicine. Primary care physicians should be at the cornerstone of diabetes care, while patients with complex insulin regimens or at risk for severe hypoglycemia or complications often need to be referred to specialists to assist in management. 90% of patients with diabetes can successfully be managed in primary care settings. Yet Dovey argues that the need to customize care across a broad spectrum of medical care offers more opportunity for error than more highly regulated, procedure-oriented hospital-based care. And Heller argues that primary care physicians are less confident, less knowledgeable about the risk of insulin management and hypoglycemia when compared to specialists, and thus may not be actively and adequately assessing and managing the risk of hypoglycemia for each patient. Clinical inertia refers to the situation when there is a recognition of a clinical problem, for example, a history of hypoglycemic episodes, but no initiative to act upon it. For example, reticence to adjust target or tardiness to review insulin therapy. Clinical inertia is essentially a pattern of behavior. O'Connor et al. Postulate 3 classes of factors leading to inertia: those related to the patient, those related to the system, and factors related to the physician. The focus of this thesis is the phenomenon of physician clinical inertia. Agila et al., in their article, identified factors associated with clinical inertia, stated that clinical inertia has been recognized as an important barrier contributing to inadequate management of chronic diseases, particularly in the context of those with asymptomatic conditions such as diabetes, where therapeutic decisions are mainly influenced by assessment of evidence-based clinical outcomes. True clinical inertia must be distinguished from watchful waiting. Watchful waiting is a careful, thought-out decision to withhold action. Gerard Reach argues that the physician behavior falls under this phenomenon of clinical inertia if and only if a guideline exists, explicit or implicit. The doctor knows the guideline. The doctor thinks that the guideline applies to that patient. The doctor has the resources to apply that guideline. And when conditions 1 through 4 have been met, yet the doctor does not follow the guideline in the case of the patient. This brief literature review reveals that the majority of diabetic patients are cared for in primary care settings. Hypoglycemia is frequently underestimated in routine diabetes care, and physician clinical inertia is a common phenomenon in primary care medicine. Therefore, clinical inertia in management of hypoglycemia in primary care setting is a relevant subject for research. This thesis focuses on 2 objectives. The first objective was to create a clinical inertia scale around family physicians' behavior in managing hypoglycemia in their diabetic patients in primary care settings. And should a robust factor structure be found for the clinical inertia scale, the second objective was to determine if there was a correlation between physician clinical inertia and family physician characteristics. The starting point for this study was provided by a recent Canadian nationwide study on hypoglycemia, the project entitled Understanding the Impact of Hypoglycemia on Diabetes Management, a Survey of Perspectives and Practice, called the InHypoDM study. This thesis consists of a secondary analysis of the family physician dataset obtained from the InHypoDM healthcare provider questionnaire. It explored clinical and the InHypo study explored clinical and personal perspectives, practices and behaviors related to hypoglycemia in diabetes, as well as factor influencing hypoglycemia management from the perspectives of 3 distinct populations: patients with diabetes, people who have significant others with diabetes, and healthcare providers. The statistical approach for this thesis was exploratory factor analysis. This method allows the researcher to identify possible underlying concepts in a given group of answers to survey items that could lead to a theory. Once the score was established, bivariate analysis and multiple linear regression were conducted to examine the relationship between clinical inertia score and family physician characteristics. The InHypoDM study used a mixed method approach with quantitative and qualitative methods used at distinct stages of the project. 671 healthcare providers who provide diabetes care completed the questionnaire. These respondents included endocrinologists, family physicians, nurse practitioners, registered nurses, dietitians, and pharmacists. The sample for this thesis consisted of the subset of 162 family physicians who completed the questionnaire. The first objective of the thesis was to create a clinical inertia scale. And because clinical inertia is essentially a pattern of behavior, the potential items for the inclusion in this score were the 13 questions in that section 3 of the questionnaire that asks family physicians about what they believe to be true about their actual practices and behavior. These are the 13 questions. The answers were chosen from a 5-point Likert scale: never, rarely, sometimes, often, and always. The independent variables analyzed in this study were age, sex, years in practice, location of practice, Canadian province of practice, practice type, country where the respondent obtained medical degree, mean number of diabetes patients seen per week, diabetes educator designation, and a personal diagnosis of diabetes. Exploratory factor analysis was the chosen statistical technique to address the first objective of this study, to create a clinical inertia scale. There are two main purposes or applications of factor analysis: data reduction and exploring theoretical underlying structures. It allows the researcher to examine all the relationships between individual variables, grouping together variables that are correlated in order to extract latent factors. These factors should reflect the underlying processes that have created the correlations among variables. A number of assumptions were verified in order to proceed with exploratory factor analysis. Adequacy of sample. Factor analysis requires a robust sample size with strong correlation among variables. Normality of assessment. Violation of the assumption of normality is desired. Factor extraction method was chosen based on the distribution of data. Rotation was performed to find the simplest and clearest structure for ease of interpretation. Exploratory factor analysis was used in this thesis in an iterative process to identify correlation among the 13 potential clinical inertia items that could contribute to a clinical inertia scale. Once the stable factor structure was identified, clinical inertia score was calculated based on the mean value of the scale items. A factor score is a useful outcome of exploratory factor analysis. They are estimates of the score that subjects would have received on each of the factors had it been possible to measure them directly. The simplest procedure for achieving this is to calculate the mean value of each response in the questionnaire for each respondent. This method was used to calculate the clinical inertia score, which was then treated as a continuous outcome variable. Bivariate analysis and multiple linear regression were conducted to examine the relationships between the outcome variable, the clinical inertia score, and independent variables. Continuous independent variables were analyzed by Pearson's correlation. Dichotomous variables were analyzed by t-tests. Categorical variables with more than 2 categories were analyzed by ANOVA. Tested assumptions underpinning multiple linear regressions were adequacy of sample size, absence of multicollinearity, absence of outliers, normality, linearity, and homoscedasticity of residuals. The results we found were, the respondents were 56.2% males, 43.8% females. The mean age was 57.5 years. Respondents had been practicing medicine for a mean of 26 years. The average number of diabetic patients seen by these family physicians per week was 27. 9 respondents, 5.6%, affirmed having diabetes educator designation. The majority, 75.3%, were from urban areas and 24.7% from practice in rural areas. Family physicians reported that they practice in hospital, 4.9%, family health teams, 30.9%, and other settings, 64.2%. Most family physician respondent practiced in Ontario, 54.7%, and the majority of respondents obtained their degree in Canada, 84.5%. 9% had a personal diagnosis of diabetes, of which 46% reported having experienced diabetes-related hypoglycemic event. The 13 items of the actual practices and behavior section of the healthcare provider questionnaire were subjected to iterative rounds of exploratory factor analysis using SPSS version 25. Prior to performing factor analysis, the suitability of data was assessed. Inspection of the correlation matrix revealed many strong correlations between items. The KMO value was 0.92, and Bartlett's test of sphericity reached statistical significance, supporting the suitability of data. The chosen extraction method was principal axis factor technique due to the observation that there was not a normal multivariate distribution. Rotation was performed for achieving a simpler structure for ease of interpretation. Because the 13 potential clinical items were correlated, the oblique technique of rotation oblimin was chosen. 4 rounds of iterative exploratory factor analysis were performed. The process is described as follows. The first round, all 13 items were included. 3 factors were found, however, factor number 3 was poorly defined, having only 1 variable loaded, and was excluded from the analysis. A new round of factor analysis was conducted with the remaining 12 items. Second round, 12 items included, 2 factors were found. Though statistically distinct, clinically they did not represent 2 different concepts within clinical inertia. Another round of exploratory factor analysis was performed that restricted the analysis to a single factor. This was the third round, so all 13 items were included to observe how they would behave in a 1-factor solution. One item, the same one that was excluded in the first round, presented a poor loading value and was again excluded from the analysis. So a 4th round of exploratory factor analysis was conducted, restraining the remaining 12 items to a 1-factor solution. The factor correlation matrix for this solution presented all loading values greater than 0.4, and it explained 54% of the total variance. This process indicates that these 12 items of the actual practices and behavior section of the healthcare provider questionnaire were suitable for clinical inertia score. The clinical inertia score variable was created by calculating the mean of the response for each of the 12 items for each respondent. Normality assessment showed a normal distribution of the score variable. Mean value was 3.82 with a standard deviation of 0.61. Having constructed the clinical inertia score, now I turn to the second objective, determining the correlation between the outcome variable and the family physician characteristics. Bivariate analysis was performed, and no significant association between independent variables and the clinical inertia score were found. Multiple regression was used to assess the ability of these 9 independent variables to predict score on a clinical inertia scale. Preliminary analyses were conducted to ensure no violation of the assumptions of normality, linearity, multicollinearity, and homoscedasticity were performed. Normal probability plots were inspected, and the residuals rested well along the line, indicating that both normality and linearity assumptions were met. Multicollinearity was verified by examination of the correlation matrix. The variable age was highly collinear with variable years in practice, with a bivariate correlation of 0.826 with statistical significance. Therefore, the independent variable age was excluded from the regression, and a second multiple linear regression was performed. Assumptions of normality, linearity, multicollinearity, and homoscedasticity were met for the second multiple linear regression. And none of the relationships examined in this final multiple linear regression reached statistical significance. The major and novel contribution of this thesis is the development of a practical measure for clinical inertia. The use of this tool is intended to precipitate physician behavior modification towards critically applying guideline recommendations to their practice and ultimately improving outcome for people with diabetes. Existing literature addresses other aspects of diabetes care and clinical inertia. In those studies, women, recent graduates, and physicians working in teams were less inclined to clinical inertia. The results found in this thesis showed that for this population, none of the differences in the clinical inertia score found in the family physician characteristics variables achieved statistical significance. Propensity to clinical inertia behavior was not evidenced across Canadian provinces, whether the family physician worked in a rural or urban setting. Nor did inertia on the part of the physician vary inversely to the volume of diabetic patients seen per week. A designation of diabetes educator was not an advantage in preventing clinical inertia, and a personal diagnosis of diabetes did not lessen nor encourage physician clinical inertia behavior in hypoglycemia management. Given that some physician characteristics are not amenable to change, such as age, sex, nationality of medical degree, and personal diagnosis of diabetes, they do not provide opportunities for intervention to change behavior, and so would be of limited practical value in tackling the problem of clinical inertia. Optimistically then, the lack of significance in these results may suggest that other facets of care amenable to change may be the most strategic approach for interventions. The strength of this study is that it raises awareness and addresses an issue relevant to primary care and family medicine worldwide, that of clinical inertia in hypoglycemia management in primary care settings. Exploratory factor analysis allowed for observation of underlying constructs where no specific theory was available to explain the phenomenon. This makes it an appropriate choice for statistical analysis for a primer study. Data for the analysis were supplied by a major study designed and executed under a rigorous scientific method. Respondents were from across Canada, representing a nationwide sample. Recognizing the possible limitations of this study is key to improving future research. One limitation is that the survey used in this study was based on physicians' self-report of their behavior and may not reflect actual behavior. Because of the secondary data analysis nature of this study's design, key aspects that could measure clinical inertia were not present in the original questionnaire, such as attitudes and behavior of the physician in relation to patients' results on glycemic target, or questions about the use of electronic medical record, telehealth, and other technology-driven clinical intelligence tools that could aid physicians in protocols and practice guidelines. The original question about practice type was not precise enough to classify the team-based characteristics of the physician practice. Reclassification was conducted to mitigate for this problem, but the recoding criteria were not free from subjectivity. The item that was deleted for statistical reason referred to the presence of competing demands on the patient-doctor encounter. This is an issue that should be explored in future research in order to better understand its contribution to the phenomenon of physician clinical inertia in managing hypoglycemia in primary care. This clinical inertia score can be an important and useful tool for family physicians and primary care services that wish to improve delivery of care to diabetic patients, specifically in the management of hypoglycemia. The study is the first of its kind that explores a clinical inertia measurement for hypoglycemia management in primary care, and as such, it serves as a primer, a basic foundation for future research to test, validate, and build upon. The creation of the clinical inertia scale for hypoglycemia management is the first step in the development of and validation of a scale to measure an important and largely understudied clinical issues. It is hoped that further validation of the scale will happen over time as it is tested in other family physician populations. Thank you for your attention. I welcome your comments and questions.
We've got time for a few questions.
Okay, good. Yes, please.
I commend you for all of the work you've done in scale development. It's not an easy process, and it's kind of iterative, difficult process, analyses. I've got two questions. One I will call the real, and the second I will call the ideal.
Okay.
Ideally, if you were to develop a question scale based on preset questions in which the construct and content validity were not there. In other words, the questions weren't developed thinking through what would be some of the issues or variables or constructs that would relate to inertia. So you basically took what's there and you pulled it together. Ideally, what different constructs, if you were to start from the beginning to develop an instrument, what constructs would you like to include that could be used in a scale? In other words, developing a questionnaire in the first place and then going through factor analyses to see whether the constructs are together.
I would say that understanding why physicians do not follow guidelines and maybe try to understand that. Is it because of competing demands? Is it because of time restraints? So the setting in which the encounter takes place and those factors, maybe those are system factors perhaps, but I would look into that. And electronic medical record from my practice is something that really helps us, keep the guidelines on this sidebar here so that I have the patient, but I don't forget the guidelines. So I don't deviate too much from what is supposed to be optimum care. So I think technology can help us in this, and this wasn't considered at that point, at that moment, when the original questionnaire was designed. So
that could expand the constructs in terms of the scale, because if you only have one factor, then maybe there's other factors that are missing from it.
yes, of course.
So the real question is, so what type of validity and reliability psychometrics do you think you could do in the future to further validate the scale that you have? What would your future plans be?
Well, we could control for some of these differences. I work with a group of about 300 family physicians. They work in pretty much the same setting. We work in teams, and we have electronic medical records with protocols. And so it would be interesting to test such a scale in this group and see controlling for that, because they all have pretty much the same time slot for a patient encounter and same protocols, and see how controlling for those, how they, what characteristics do we find that could indicate more propensity or less propensity to, not follow guidelines.
So, like predictive validity, that
Yeah.
would be something to
Yeah.
do. Are there any other similar scales that you could do some concurrent validity assessments on?
There was nothing in the literature about hypoglycemia clinical inertia. We did find something about hyperglycemia clinical inertia, and it was very restricted to glycemic target. So it was they analyzed it afterwards, after the consultations, and they saw that family physicians, even though glycemic target were off targets, they did not adjust. They did not adjust therapy, and so that was considered clinical inertia for that study. But it's still a lot poorer in terms of information than what we looked at, as in behavior and different aspects of behavior. So, yes.
Fabulous. I'm very impressed, and I think that it was sort of exploratory factor analysis 101 in 20 minutes. And I really appreciate the clarity that you brought to that presentation. I'm really curious in terms of your thoughts about future research and opportunity for future research in Brazil, and where research is going from that perspective. Would you gain support for something like this, do you think, in Brazil?
I think so. I don't want to talk about the company where I work, but primary care is gaining momentum in the supplementary system. So this is a different, maybe if any of you ever read about Brazilian health system, we have a universal health system. But there is a supplementary system for, because of all the flaws of the public system. And primary care is gaining attention, and that's the moment where we're at. So we actually have a large shortage of family physicians, because everybody all of a sudden thinks that in the supplementary system that, wow, these guys have something to offer, let's hire them. And that's the movement where Gusso was in. He's really a pioneer in that area. And so with that comes measurements, right? So we're making changes, let's measure these changes. And that's where research really comes in, and they're supporting this. Because really the people who are supporting this change, they want to show the world how this can be helpful. And so.
Thanks, Carolyn. I think what you bring is sort of an international perspective. I mean, you're working with Canadian data as a Brazilian physician in a Ontario master's program. So I just think it's got to, you've got a very important lens and a very different lens to bring to this. So I appreciate that.
Go ahead.
So the clinical inertia scale that you came up with, first of all, awesome presentation. It was very clear. I agree. I think you really described the clinical context as well as the methods that you used to come up with your construct. So just to clarify, is that a measure of clinical inertia itself? That is like essentially could be like an outcome for a future intervention that may be targeted at, for example, like a specific behavior change quality. So clinical inertia in this case could be like the outcome for an intervention study.
Clinical inertia is a very complex and not easy to define. In the literature, you'll find different definitions of what is clinical. I presented one definition, but there are others. What we found is a tool. So we need to use this tool and cross the results from this tool with clinical outcomes so we can understand exactly to what extent it measures, right? So we were talking about this, and it is like finding a thermometer, but you don't really know what fever is supposed to measure. You need to test it out. You need to first make sure that this thermometer can be tested in other populations and see what needs to change or maybe refine.
Yeah.
Okay.
Yeah, I think that's very interesting because you have this very cool clinical inertia measure, which I believe without seeing the actual items, and then based on the criteria that you gave, form like at the beginning of the presentation around what clinical inertia is. I bet you that the scale that you created actually contributes a lot to what might be a good definition or an improved definition of clinical inertia. And I agree, looking at how that relates to outcomes and like hard clinical outcomes would be interesting. And then I'm also curious to see how maybe behavior change interventions based on, behavior change theory that already exists could then impact clinical inertia as a kind of mediator between, those factors. And then
That's a good theme for maybe a next research project. Thank you.
Your PhD.
Oh, my PhD. Oh no, I was going to say her PhD. Okay. All right.